Thank you, everybody. Bismillahirrahmanirrahim. Let's start the first thing. I will be talking about, are we prepared for the challenge in this part of the world because of the rising incidence of diabetic retinopathy on this part of the world. And we haven't done much about it so far. So what are the challenges that we have to face? हमारे एक मेहमान आए हुए हैं इंग्लैंड से, शुएब चौधरी साहब. वो बैठे हैं इस वक्त या नहीं बैठे हुए? He will be talking on screening that they have designed in England. So we wanted to design some sort of a similar program in Pakistan as well. So what are the current global challenges? 80% humanity lives less than $10 per day. We all know that. 2 million people doesn't have a safe drinking water that is applicable to this part of the world. And the fertility rate, the Pakistan has got the highest thing, 3.5. And the world is dangerously close to the World War III, as we all noticed recently. And the slashing in the global funding, this is another challenge that we are facing. The new American order, the tariff, WHO funding, because America has plugged off the funding to the WHO recently. So they are not financing any health project to WHO. And they have also cut $9 billion in foreign aid. And US aid is almost negligible to the world. So what will happen to this part of the world? हम तो पोलियो वैक्सीन भी बाहर से मंगवाते हैं. हमने आज तक अपनी पोलियो वैक्सीन भी नहीं बनाई. तो हाउ वी आर गोइंग टू फेस दिस चैलेंज? तो व्हेनेवर आवर वर्ती प्राइम मिनिस्टर हमारे यहाँ जो भी जब ओथ लेता है तो सबसे पहला काम ये करता है कि वो अमेरिका जाता है और अमेरिका जाके वो एक शख्स के पाँव पकड़ता है. उसका नाम है बिल गेट्स. और बिल गेट्स के आगे वो हाथ जोड़ के खड़ा हो जाता है कि खुदारा फंडिंग मत बंद कीजिएगा पोलियो की, क्योंकि हमारे यहाँ उसकी मरातें लगी हुई हैं, लोगों की नौकरियाँ लगी हुई हैं, लोगों की गाड़ियाँ आ रही हैं, उस पर पेट्रोल डल रहा है, अयाशियाँ चल रही हैं. खुदा के लिए ये पोलियो की जो है ना फंडिंग बंद मत कीजिएगा. तो ये तो दिस इज़ दैट वी हाउ मच वी डिपेंड अपॉन द फॉरेन एड. सो द ग्लोबल फंडिंग ऑफ US aid and WHO, what will happen to the TB, malaria, HIV, hepatitis, and the most important, the upcoming challenge in diabetes and diabetic-related blindness in this part of the world. Diabetic retinopathy indeed is a rising global challenge for us, so we have to think about it and we have to do something about it as well. This is the sorry state of the news that I put it here. Bill Gates Foundation to support WHO effort to help flood hit people. अभी रिसेंटली जो फ्लड आया था उसके लिए भी हमने बिल गेट्स का जाके दरवाज़ा खटकाया था कि भाई कुछ हमारी मदद कर दें. तो this is the current situation. This is the International Diabetic Federation data in front of you. And Pakistan will rank globally number 3. And it will be by year 2050, we will be on the top of the list in the world as far as the diabetes is concerned. And 1/3 of the cases in Pakistan, they are undiagnosed. हमें पता ही नहीं है बेचारों को शुगर होती है. वो तो when you do the test, जब कैटरेक्ट के लिए मरीज आता है, जब आप टेस्ट कराते हो तो then they came to know कि वो तो डायबिटिक पेशेंट्स निकले. लोगों को पता ही नहीं होता. These are the factors: lack of preventive measure, limited access to the health care, high prevalence of diabetes, type 2 diabetes, and the most important, the role of GP, diabetologist, ophthalmologist, and the lady health workers. Majority of the lady health workers which were inducted during the political governments, they were inducted because of the political will कि इनको भर्ती कर लेते हैं, कल को इस पूरी फैमिली के वोट तो हमें मिल ही जाएंगे ना. Are they doing any work on the field? That's still a question mark. And what about the role of GP? Are the GP referring these cases to a diabetologist? We are the ophthalmologist who most of the time diagnose कि बंदे को diabetes है, then we refer to the GP or the diabetologist. हमारे पास रेफर होके नहीं आता कि the patient को ये diabetes है, इसकी ज़रा आँखें वगैरह चेक कर लें. That never happens. हम भेज रहे होते हैं कि भाई आप इसको डायग्नोज हमने कर लिया है, कैटरेक्ट का ऑपरेशन था, ना इसकी आप शुगर कंट्रोल करें. द करंट चैलेंजेस और डायबिटिक रेटिनोपैथी, जिसके लिए हमें स्क्रीनिंग के लिए हमें फंड्स चाहिए, फंडस एग्जामिनेशन, ह्यूमन रिसोर्स डेवलपमेंट, स्क्रीनिंग एंड रोल ऑफ आर्टिफिशियल इंटेलिजेंस. To develop the whole structure, we need the comprehensive funding. We need to have a comprehensive planning. And we have to think about it. Ultra-wide field fundus camera, which Muhammad was talking about yesterday on this issue. अगर हम ये ख़रीदते हैं तो it cost about 80,000 pounds, as Shahzad said yesterday. Dilated fundus examination, yeah, non-mediatic cameras that cost you. So no doubt the unmet need of anti-VEGF treatment for DME, that's another challenge that we have to face. Screening, this is a very important subject. Because of the growing population in the world, we have to design a comprehensive screening program in this part of the world, which we will be talking. There's instruction course by the Shoaib Chaudhry Saab today between 4 and 5 o'clock in the Pearl में है ना शायद Pearl Hall में है. तो हम उनसे ये चीज़ें सारी डिस्कस करेंगे. तो आई विल रिक्वेस्ट एवरीबडी है ना, आप भी आ जाइएगा, इसको ज़रा डिस्कस कर लें आज कि व्हाट वी आर सपोज टू डू एंड व्हाट वी शुड डू एंड व्हाट शुडंट बी डूइंग. These are the certain few important articles. अगर आप इनका स्क्रीनशॉट ले लें related to the artificial intelligence as far as the screening is concerned, this might help you. These are the two articles. One thing I wanted to highlight here, these are the organizations in Pakistan, they're involved in diabetes management. Number one is the Diabetic Association of Pakistan, then International Diabetic Federation, and another is the WHO. मैं International Diabetic Federation और WHO की तो बात नहीं करता. They are doing some work internationally. Let's come back to the Diabetic Association of Pakistan. Is a member of IDF and played a significant role in providing specialized medical care, education, advocating the national diabetic guidelines and policies. This is absolutely rubbish. ये इनकी वेबसाइट पे लिखा है, वहाँ से मैंने उठाया. ये कुछ नहीं करते. ये 14th of November को एक डायबिटिक डे मनाते हैं, एक दो तस्वीरें खिंचवाते हैं और तालियां बजाकर ये ख़त्म हो जाता है. They don't do anything. So we have to think about it कि हम यहाँ पे हो क्या रहा है. सिर्फ एक डे मनाया जाता है, डायबिटिक डे, that is the 14th of November. That's it. That's the only activity they do it. No doubt the anti-VEGF is the most effective treatment for the diabetes. Because of the high rate of recurrence and frequent injections, that's another financial burden on us. So this is one of the biggest challenge. And obviously when you are treating the diabetic macular edema, at times it is very resistant and you need a long-term treatment for that. So this is another challenge for us. What is the role of OSP and MRAP? OSP is basically an organization, they are doing the training and teaching, and the medical retina subspecialty we have to develop for future point of view, and this has to be recognized by the College of Physician Surgeons. Recently, we introduced the Master Retina Class Certified Program for the few trainees to do the job in periphery. This is another step. And the Blindness Control Program by SIOVS PICO, they are mostly developed in human resource development. And we published the guideline from the MRAP, and certainly we will do something about it. And the most important thing is a collaboration with the Euroretina and BPOS, and also to the international NGOs as well. Without the help of the international NGOs, these challenges we cannot fulfill at all. Recently, SIOVS has signed the MOU with Roche, and they will be providing the free Vabysmo injections for the needy people, particularly diabetic macular edema. So this is a good step, but this is again with the help of various NGOs. They will be helping us out, like Sightsaver, Fred Hollow Foundation, Queen Elizabeth Diamond Jubilee Trust, and the CBM. CBM stands for Christopher Blandin Mission, and they are playing a very active role in Pakistan currently. So the time is up now. Thank you very much, ladies and gentlemen. These are the challenges we have to discuss.
Thank you for invitation again, and I will talk about recent advance in management of diabetic macular edema. I think Dr. Tariq, he mentions some obstacles that we are facing in management of diabetes mellitus and the consequences, diabetic retinopathy and diabetic macular edema. Even though there is in the recent year there is a significant advances in the management of diabetic macular edema have been achieved, and these are the emerging breakthrough in the bringing the new medications, either the anti-VEGF or steroid. With this advancement, the future of DME management is looking brighter and more hope for better quality for those have affected with these sight-threatening conditions. But even though all this what we are having, still we are having a challenging in managing of diabetic macular edema. Some of the patients, they are not responding adequately, and we are facing around 40% of the cases they are not responding. There is a durability and efficacy and safety of the available treatments. The durable is not that much, so still there is a good achievement happened in the last 3 or 4 years in the durability effect and the efficacy and safety, but still it's not that what we are looking for if we want to treat the diabetic macular edema. Cost burden, I think this is very, very important, especially maybe here in Pakistan. Even in the rich country, I think in advanced and developed country, still they are facing this one. It's not a simple things that we are talking about. They are taking a lot of the sources of the healthcare systems. So cost burden is very important to take care about and to see, and it is something that need to be solved to make more facility of this management of diabetic macular edema. Compliance of the patient with the frequent injection and follow-up is another sort of challenge. So there is a potential role of artificial intelligence in the also management of diabetic macular edema. So DME treatment evolutions, as you know, in the earlies, before we start only, we are having only one source of management that was only laser treatment, which was the gold standard treatment for a long period of time. Then the era came of the anti-VEGF, which started in 2006 by Avastin, which was an off-label medication. Then the story continued until we reach now in the last, which is the Eylea 8 milligram, and faricimab is the last two molecules that we are having now as a source of management of the diabetic macular edema. So the real world setting, if we are looking what we are facing, is it what we are having in the clinical trials? It doesn't actually replicate what is going on. So the real world, that the number of injection is around 4% or 4 injections. What is recommended is 10 or sometimes 12 injection. So because of the compliance of the patient and other and cost burden, so we are not giving a correct number that simulate the clinical trials, and that's why we are not getting the benefit of this treatment adequately. So what are the latest managements? As you know, brolucizumab, one of the molecules that we get in the management of diabetic macular edema. There is some sort of intraocular inflammation of these molecules, but really it is one, I think, in my opinion and in my experience, I think this is the most power anti-VEGF that we can use in management of either diabetic macular edema or AMD, but as we are concentrating on DME, so this one is have a very good effective and drying under macula, and sometimes only one injection you will find that everything is resolved. But still we are having a fear of intraocular inflammation, even though it found in the trials that in case of diabetes mellitus is less in comparison to what is seen in AMD. I will go this because I think the time is running. So there is a good achievement in the improvement in the visual acuity and drying in the macula, and we can reach up to 52% in Q8 weeks, and sometimes in Q12 around 22% of this. The other one, there is a Q8, it reached in the Castrel Q8 in 60 or 70% of the cases. Overall safety, as I mentioned, it was found it is not similar what is seen in AMD, but is more less in compare with the diabetic macular edema itself. Also, there is another study was done not related to approvals, and it shows also the same. So why does the seems that's better safety in profile regarding the pralucizumab? This is a speculation or possible explanation that inverted female to male ratio in AMD versus DME patients. Female gender is associated with higher incidence of intraocular inflammation as seen in IRIS or Komodo. Less treatment emergent antidrugs antibodies, including N antibodies in DME RVO versus wet AMD. And the most important, I think, younger population in DME versus wet AMD. So this is one of the cases, diabetic patient, and this is the BOV injection. Both first injection, you can see in one injection is just give a drying of the macula very fast. Both second injection, both third injection, this is in the right and the left eye. The second molecules now which available, also faricimab. I don't know if you are here already are having faricimab, but I think it's available. So also this is a new way of management, and they are having a dual mechanism, and this is as an angiotensin 2 and anti-VEGF, and it seems that it's more as a dual mechanism and have a synergically reduce choroidal neovascular leakage, and also inhibition synergically reduce leukocyte transmission. So as an anti-inflammatory and anti-VEGF, and these molecules that give a more durable effect in as it's claimed. This is also the study, and the most important, I want to show that we can reach up to Q16 durability in more than 50% of the cases. There is a good response in the drying of the macula or improvement in the visual acuity. So in Q12 weeks, we are reaching up to 80% of patients. So after the loading dose, and if the response is very well, so you can do an interval up to 3 months. In more than 78% of the patient. This is one of the cases, and this is really something that I face. This case came to me, and she was treated almost more than 1 year or 2 years in United States, and came to UAE, and she was pseudophakic and treated with multiple injection of Eylea and Ozurdex, and it's also I have done the same, but it doesn't resolve at all. And when I start, then we get the faricimab the chance to use this medication. So this is the how the OCT before the injection, and just after first injection, we can see, and this is the first time for this patient to have resolve and drying of the macula and little bit improving of the visual acuity, because it's a long-standing diabetic macular edema with ischemic changes. So I will go very fast because the time. Aflibercept is the latest one, is 80 milligram, and there is a photon study design, and they are evaluating, and now we are reaching by aflibercept, even they are claiming up to 20 weeks, and sometimes they are 24 weeks durability effect. And it reached to about more than 93% in Q12 and about 90% in Q16. And I don't know if there is, they are telling there is a Q20, but the percentage I don't have. So the take-home message: management of DME improving with new molecules in relation to best corrected visual acuity, durability, and safety. We are still on need for a better and optimal medication to treat DME. Availability of different molecules for treating diabetic macular edema give us capability of selecting suitable molecule for our patient. Thank you very much.
Jamal Siddiqui for his study of diabetic retinopathy in Upper Sindh.
Now, as we know that the loss of the vision occurs due to certain diseases, and diabetic retinopathy is nowadays becoming a global challenge in the world. Now, in the Upper Sindh, we did a study in some of the institutions at Janka Medical College, Ghulam Muhammad Mahar Medical College, and Khairpur Medical College. So, of course, it is a global epidemic, and prevalence is about 463 million it was in 2019, and it is expected to increase 700 million in 2045. Diabetic retinopathy, most serious cause of blindness influenced by the risk factors. Prediction of diabetic retinopathy is by duration, and the incidence is 27% in 5 to 10 years. 71% in more than 10 years, and 90 to 95% after 30 years. We classify it, and it has been classified in non-proliferative and proliferative diabetic retinopathy. Among non-proliferative diabetic retinopathy, it is further classified mild, moderate, severe, very severe, and same is with the proliferative diabetic retinopathy, early, high risk, and advanced. Macular edema can be present at any level of diabetic retinopathy. Macular edema is more common cause of visual loss in diabetic patients. And severe visual loss, even if there is proliferative diabetic retinopathy, if the macula is not affected, the vision can be good. But when the macula is involved, even in non-proliferative diabetic retinopathy, there is severe loss of the vision sometimes when there is severe type of the diabetic macular edema. We depend on the management of diabetic retinopathy. It does not mean that we have to just treat it, but we have to control the risk factors also. So the blood sugar control, monitor and control of risk factors, and other modalities are the intravitreal injections, anti-VEGF and corticosteroids, suprachoroidal injections of corticosteroids, laser photocoagulation is generally recommended for eyes with clinical significant macular edema and high-risk proliferative diabetic retinopathy. PRP for proliferative diabetic retinopathy. And when we started our career in medical retina, when I was training at JPMC, then we used to perform macular grid for clinical significant macular edema. But nowadays we suggest that when there is a medical option for the diabetic macular edema, we can treat it with intravitreal injections, corticosteroids, so that the macular edema is subsided, vision is improved. Then we can go for fundus fluorescent angiography and see if there is any leakage. We can perform focal laser instead of grid laser because it is a destructive procedure. It can cause further loss of the vision. Even if there is severe macular edema and we are performing macular grid, it does not work because due to severe diabetic macular edema, the penetration of the laser is not as much good as it is when after the subsiding of the macular edema. So this was hospital-based descriptive study done in these various institutions. Now, of course, we used to perform the retina clinic. We did it in Larkana and Sakhar and then Khairpur. After all this protocol of history examination, all these examination steps and protocol we observed, and investigations, of course, we have to investigate whether this patient has various problems, blood pressure, renal problem or renal profile, blood sugar, lipid profile, all these things. And coming to the treatment modalities, conservative in NPDR, patients were advised to control the blood sugar, diet, reduction of weight, exercises, and biannular ocular examination. Anti-VEGF laser photocoagulation was done in clinical significant macular edema, severe, very severe NPDR after FFA, showing capillary non-perfusion, and proliferative diabetic retinopathy. Now, these are the results. 68 patients, 126 eyes, age 22 to 75 years, and male-female ratio. Male ratio was more as compared to the female, because in our region the females are live in very restricted environment, and they are not able to approach the tertiary care centers and the ophthalmic centers. 126 eyes examined, NPDR 67 eyes, 53%, PDR 59, 47%, and clinical significant macular edema, 45 eyes with non-proliferative diabetic retinopathy and 6 eyes with proliferative diabetic retinopathy, total 51 eyes, 40%. Vitreous hemorrhage was seen in 16 eyes, 12%, and tractional retinal detachment in 6 eyes, 4%. Now, if there is a vitreous hemorrhage along with the non-proliferative or in proliferative diabetic retinopathy, of course, then we have to see if there is any role of anti-VEGF. We can control the vitreous hemorrhage so that it can be resolved with anti-VEGF. And if it is not resolved within 3 months, then we can go for the vitreoretinal surgery, pars plana vitrectomy, and endolaser. And tractional retinal detachment can also be treated. Laser photocoagulation can be done in proliferative diabetic retinopathy when there are new vessels on the retina, on the disc, and elsewhere. We can perform PRP, and laser has a good, it is the treatment of choice in proliferative diabetic retinopathy. But when it is associated with vitreous hemorrhage, then we can treat it with medical treatment, intravitreal anti-VEGF, so that the vitreous hemorrhage is resolved. If it is resolved within the period of time, then we can go for PRP. But if there is a severe type of the vitreous hemorrhage, we can go for pars plana vitrectomy and endolaser at the same time by the VR surgeon. So these are the few pictures of my cases. You can see the new vessels at the disc and vitreous hemorrhage. Here also new vessels on the disc and tractional fibrovascular membranes. So 100 eyes were treated, level of visual acuity, number of eyes and percentage. It was improved in 38%. It remained same in 38%, but it deteriorated in 24% of the cases. These are the post-laser pictures. Even with tractional membranes, you can see with fibrovascular membranes, when the vitreous hemorrhage is resolved, these membranes are already there, but you can sufficiently perform the laser and you can save the eye and patient can see. Here, there is laser has been done, fresh laser, but with vitreous hemorrhage. So if any area which is clean, you can perform laser, you can save the eye, if there is vitreous hemorrhage in some part of the retina, then you can treat it with medical and intravitreal anti-VEGF treatment. Same picture over here. So coming to the conclusion, in this hospital-based descriptive study, we conclude non-proliferative diabetic retinopathy is more common. So we can advise the patients to control the risk factors, and the regular monitoring and you can say follow-up is there, and then it can be saved from going into the severity of the disease. Laser photocoagulation improves the vision in those patients who are early treated, who has no vitreous hemorrhage and tractional retinal detachment. Thank you very much.
Thank you, Professor Shahid Jabal. Our next speaker is Professor Hamid Mahmood.
I think it's a repetition of my talks which I've been giving at the last 2 or 3 conferences. And at the cost of repetition, my target audience is the residents which are actually present in every meeting, and they don't get time to travel or resources to travel to each and every meeting. ये यहाँ से कर्सर आगे होता है. I like the term coined by Professor Shahid Jamal, anti-VEGF PRP, which is technically correct. Right, so this is the timeline on which the diabetic retinopathy treatment evolved, and it is a story for the last, from classification to current status is about a century. And the region, according to the WHO in which we are living, the Middle East, the Pakistan is not included in the region sharing with India. So MENA stands for MENA, and the highest incidence projected in 2050 is in this region, second to the Africa, which is again a surprise. And Pakistan stands on top of the age standardized diabetes prevalence, which is going to increase from 31% to 34%. And we all know that the proliferative diabetic retinopathy, diabetic macular edema, and neurodegeneration follow the cascade of chronic hypoglycemia. And the spectrum of diabetic retinopathy spreads from non-proliferative to proliferative. And this is what the way we were handling proliferative diabetic retinopathy at the end of our training. Focal photocoagulation, grid with a lot of reservation, and PRP. And then in came anti-VEGF. And now, the question which I frequently, this is the era of evidence-based medicine. तो आपके पास evidence क्या है? Luckily DRCR नेट का प्रोटोकॉल S. जैसे PRP की evidence क्या थी? Evidence based study क्या थी? Residents को अगर हैं तो was it DRS? And then it was followed by ETDRS. Residents कुछ मुझे नजर आ रहे हैं, हाथ रेज करें जरा. कोई नहीं है. अगर हैं भी तो हाथ नहीं रेज करें. हाथ बिल्कुल ऊपर करें. Because you are the target audience. और थोड़े से सवाल भी आपसे करने हैं और फिर आपने मेरे से भी सवाल करना है. So the protocol S was actually, मैं इस ग्राफ को जो इनिशियल 2 years ग्राफ था ना प्रोटोकॉल एस का, उसमें ज़रा आप ये देखें कि प्रॉम्प्ट पीआरपी में ज़रा डिप था और रेजोल्यूशन ऑफ विजुअल एक्यूटी एंड इम्प्रूवमेंट इन विजुअल एक्यूटी, और दोनों ग्रुप्स जो थे रेनिब्यूजिमैब एंड प्रॉम्प्ट पीआरपी, दोनों में एथिकल कमेटी ने इजाज़त दी हुई थी कि जी जिसमें मैकुलर एडीमा होगा उसमें उसको डिनाई नहीं करना ट्रीटमेंट ऑफ द एंटी-VEGF. सो दिस वाज द डिज़ाइन ऑफ द स्टडी. और 5 साल में देखें दोनों ग्राफ्स आके मिल जाते हैं, जैसे ब्लू नाइल एंड वाइट नाइल, और दोनों रिवर्स मीट, एंड द कॉन्फिडेंस इंटरवल्स एंड द पी वैल्यूज आर द सेम एट द एंड. तो जो स्टूडेंट्स हैं उनके लिए the way you actually evaluate the evidence is the confidence interval difference, which shows the uncertainty in the two groups, and the p-value shows the significant difference between the two groups. Or dono groups end पे give you the same results in terms of mean change in visual acuity for the overall cohort. There was a great debate. Naturally, vision impairing diabetic macular edema में तो हम we are convinced, evidence based. लेकिन mean change in visual acuity and then the visual field and dark adaptation, ये दो areas थे जिसमें एक आ गया कि the anti-VEGFs repeated would preserve the visual field to a comparatively better outcome. लेकिन मेरा क्वेश्चन ये है, देयर इज उस सेटिंग में विच इज यूएस विद इंश्योरेंस एंड नो लैक, हमसे बहुत ज़्यादा रिसोर्सेज, देयर वाज अ वेरी हाई इंसिडेंस ऑफ लॉस टू फॉलो अप. व्हाट वाज द रीजन फॉर दैट? आई डोंट नो. अब हमारे सेटअप में पहले तो डायबिटिक रेटिनोपैथी का पेशेंट आपके क्लिनिक्स में पहुंचे और फिर वहाँ पे प्रोलिफरेटिव डायग्नोसिस हो, उस बेचारे का वहाँ पहुँचना थ्रू दी फिल्टर ऑफ प्राइमरी सेकेंडरी एंड टर्शियरी केयर. जो हमारे इधर रेफरल सिस्टम सीधा पेशेंट सेल्फ रेफरल पे चल रहा है, फिल्टर्स पे नहीं चल रहा. एक लिमिटेशन. दूसरा, अगर वो पहुँच ही जाता है तो अब आप डिबेट ये होती है कि एंटी वेजेफ लगा के उसको आप वापस भेज दें, पता नहीं कहाँ से आया हुआ है. आप उसको एक टीका लगा के उसको ये फीलिंग दे कि नाउ यू आर प्रोटेक्टेड एंड यू आर ट्रीटेड, एंड दैट इज आई थिंक प्रैक्टिकली a lot of disservice to me. मैंने ये टॉक प्रेजेंट की थी जब कराची में, तो none other than साले मेमन साहब stood up and he came on the stage. उन्होंने कहा जी हामिद जो बातें कर रहा है ये तो मुझे जवाब देना पड़ेगा आगे. The great man. और मुझे इसको सेकंड करना पड़ेगा. So I think these are my sharing my thoughts with you. The very purpose of coming here on this rostrum is to share my perspective with my colleagues and with the trainees. और फिर साल में 9 इंजेक्शंस ऑन एन एवरेज लगाने पड़े, 5 साल. 9 is 35. और एक और बड़ी इंपॉर्टेंट मैसेज, इसको भी मैं इस वक्त इन द इंटरेस्ट ऑफ टाइम, look at these two ultra wide field FFAs and OCTA. The areas of capillary dropout, which actually produce the anti-VEGF, the VEGF, and then the consequent neovascularization. Anti-VEGF has nothing to do with revascularization of the capillary bed. Full stop. मैं तो सिर्फ एक मैसेज जो ट्रेनीज को देना चाहूँगा ना, वो सिर्फ ये है, एंटी-VEGF से दोबारा कैपिलरी सर्कुलेशन नहीं शुरू होगी. वो इस्कीमिया परमानेंट वहाँ पे इस्कीमिक एरिया है, उसने एंटी वेजेफ, उसने वेजेफ बनाते रहना है और उसको आप डायरेक्टली डिस्ट्रॉय भी नहीं कर सकते. तो आप सिर्फ सेंट्रल रेटिना को प्रोटेक्ट करने के लिए पेरिफेरल रेटिना को सैक्रिफाइस करते हैं पीआरपी में. ठीक है, दैट्स द वर्किंग ऑफ द पीआरपी. एंड देयर आर नो स्टडीज विच शो, एंड पे जो इसका मेटा एनालिसिस है, anti-VEGF and combination treatments could be regarded as alternative approaches to PRP alone in management of proliferative diabetic retinopathy after engaging in a shared decision making process. मरीज के हालात देखें, कहाँ से आया है, अफोर्डेबिलिटी देखें, बहुत सारे इश्यूज को evaluate करें, and patient adherence, diabetic macular edema status and preference. So what I would do if I have a patient with proliferative diabetic retinopathy and he has a wet macula, तो मैं उसको एक एंटी वेजेफ चाहे एवेस्टिन है उसका बेनिफिट जरूर दूंगा और एक एंटी वेजेफ लगा के मैं उसको शेड्यूल करूंगा फॉर पीआरपी आफ्टर 1 week or 2 weeks. That would be very practical for me. A lot of experts sitting here. And they have their own way of looking at things. और एक और चीज, take home message, even in 2025, Royal College of Ophthalmologists, nice guidelines, American Academy of Ophthalmology preferred practice pattern, PPP, और Royal College of Ophthalmology itself, first line treatment of proliferative diabetic retinopathy is PRP, full stop. Anti-VEGF is an adjunct. It just a supportive treatment in that perspective. So, the gold standard, ये कराची वाली प्रेजेंटेशन के बाद एक स्लाइड मैंने चेंज की है वो ये वाली PRP is the gold standard in the treatment of proliferative diabetic retinopathy and I distinctly remember और ये एरिया है जो WHO कह रहा है इंटेग्रेटेड पीपल सेंटर्ड आई केयर IPCEC हमने as a group, as Medical Retina Association of Pakistan, as trainees, as supervisors, and OSP, CPSP, have to make every effort to play our role in establishing this pyramid. और इसमें अपना role play करें. And then also don't forget the ABC, a good HbA1c control, blood pressure, and cholesterol levels. Thank you very much.
We have Dr. Shoaib Chaudhary, the UK-based consultant, and he would be enlightening us with new update and integration of OCT in community screening programs.
I'm Shoaib Chaudhary. I'm a consultant eye surgeon and clinical lead for diabetic retinopathy. Being a medical retina, our emphasis in England, in the Western Europe, is shifting more towards prevention and picking early the cases and hopefully reducing the burden for visual loss as well as financial. So previously, many years ago, the only treatment available was that you go to an eye specialist, he will look at your fundus and devise whether you need a treatment or you don't need a treatment. And when the fundus photography came, then we started looking at the pictures and started classifying who needs treatment and who needs follow-up. This went on for quite some time. But the problem was we couldn't pick up the cases who needed treatment in time. And even in the Western world, the incidence of visual loss was quite high in the working population. But recently, integration of OCT has changed this quite a bit. So NICE has come up with the new guidelines for following the retinopathy. Nowadays, what we are doing is instead of sending all these patients to the specialists, we have trained non-ophthalmic personnel who can look at the pictures and then, as well as OCTs, and then make a decision that what is the next step if a patient needs to be followed up in the community or they can be referred for further assessment. So this retinopathy screening has really made a difference. So this guideline was introduced in April 24, and some new terminology has also been added, and in OCTs has been integrated, which I think will be quite useful, particularly for people in this country. I would urge if there is any public health personnel that they should take a note of it. The previous guideline is the same. I will go through very quickly. R0 means there is no retinopathy. And R1 is that you have microaneurysm, retinal hemorrhages, venous loops, or any exudates and cotton wool spots. These are some pictures. I think you people are all aware of this microhemorrhages and microaneurysms. These are small circular red dots having distinct margins. Usually they are not larger than the blood vessels itself. We call them dilated capillaries. Hemorrhages are simply a rupture of a capillary. Hemorrhages can be dot hemorrhages, which are round, large than macroaneurysms. They could be blot hemorrhages, or they should be flame hemorrhages, which are in the nerve fiber layer. Now, this is M1. If you have the same changes in the macula, you call it R1, M1. So basically, hemorrhages, exudates, or cotton wool spots, or venous bleeding anywhere in the retina, we class it as R1, M1. And this is another example hard exudates, maybe white or yellow cholesterol deposits. You can have white, feathery, fluffy cotton wool spots. IRMA is another one, intraretinal vascular abnormalities. You could have spidery abnormal vessels. These are usually contorted in appearance with sharp corners and often crossing over themselves. Usually they don't cross the main blood vessels. And venous beading, the major blood vessels, they lose their structures and they become like sausage-shaped. Now, this is something new which has been introduced now for the last year, that you class R2 into low risk and high risk retinopathy. So they have put the numbers here. If there are 8 or more blood hemorrhages across 4 quadrants, or if there are 20 hemorrhages or microaneurysms in 1 to 3 quadrants, venous beading in any quadrant, or IRMA in any quadrant. So this is labeled as R2L. Now the other one is R2H, which is high risk, 20 hemorrhages or microaneurysms in each of the quadrants, venous beading in 2 or more quadrants, and IRMA in any quadrant. Now these has implications in terms of referring patients for further assessment to the hospitalized service. So R2L can be managed locally in the community, while R2 high, it is an indication they should be referred for further assessment. R3S, we know this is old, treated retinopathy, stable proliferative retinopathy. Previously, they used to be followed in HES, but we are now saying that after 1 year, you can refer them back to the community for further assessment and follow up there rather than in hospitalized service. The whole idea is to reduce the burden in hospitalized service for these patients. R3A, we are aware, active proliferative retinopathy. It could be disc vessels elsewhere, pre-retinal vitreous hemorrhages, or fibrosis, early tractional retinal detachment, and reactivation in previous proliferative retinopathy. Photocoagulation, if there is no photocoagulation, it is classed as P0. And if there has some sort of photocoagulation, we label it as P1. Again, coming on to macula, M0 is no maculopathy. Well, M1 maculopathy is, you can go through this one. The M1, any group of exudates anywhere in the macula. Again, M1. Now, this one is new. OCT has been integrated, so the classification now can be done by the non-ophthalmic personnel if they have access to OCT. If it is normal, it is negative. It could be borderline, and it could be positive. Negative is normal. All the structures are intact, so we don't need to do anything. You can see these patients 6 months or 12 months intervals in the community. Borderline is when you have intraretinal cysts. The important thing is no change in the contour of the OCT. So these patients still can be followed up in the community, or your personnel who are not doctors, they can look at OCT and just follow these patients locally rather than sending them to the specialist for further assessment. Positive are cysts with a change in the foveal contour. This is important, so your personnel, they should be able to pick that up and refer these patients for further assessment. So you can go through it. I have written the measurements there. So basically the new guidelines on referral to eye service are HES will now be able to discharge certain patients back to the community eye service for further follow-up rather than following them up in the hospitalized service. But the important thing is a physician must advise. Remember, these will not be the doctors who will be following the patients in the community, and you have to tell them, follow these patients 3 months, 6 months, or 12 months, depending upon, in your judgment, what is the severity of retinopathy. Basically, we write a letter and email to the concerned people in the community what to do with these patients. And also we mention the feature-based retinopathy status. It is R2 high or R2L or R1, M1, whatever. So at the other end, people know what you have done, so they can take it from there. And the reverse is also true, that from HES we can discharge them back to community. I think my time is up. So basically what I'm saying is that instead of following every single person in the hospitalized service or in our country based on specialized service, you should have people available in your catchment area who can do with smartphone, they can take pictures, that if they have access to OCT, they can decide there which patients to refer and which not to refer to the specialist service. So it will reduce a burden, financial as well as time, on your time. Thank you very much. Thanks.
Dr. Nasir Ahmed Memon for his talk on efficacy of SCTA in resistant DME.
Bismillahirrahmanirrahim. Al Ibrahim Eye Hospital. So today the topic of my presentation is efficacy of suprachoroidal triamcinolone acetonide injections in resistant diabetic macular edema. So I have no relevant disclosures. This is an abstract. So the diabetic retinopathy remains the leading cause of vision loss among working adults, with diabetic macular edema being the principal cause of diabetic-related visual impairment. Diabetic macular edema is the retinal thickening from the fluid accumulation secondary to microvascular leakage, predominantly in the plexiform layers. Hypoxia-induced VEGF release, increased vascular permeability, causes edema and visual loss if untreated. So the anti-VEGF therapy is now the first line of treatment, though frequent injections and poor response in some cases limit its effectiveness. These patients demonstrate suboptimal response or faces challenges with the repeated anti-VEGF dosings. So the intravitreal triamcinolone acetonide offers an alternative by reduced inflammation and VEGF TNF activity, but is associated with IOP rise and cataract. So suprachoroidal delivery of triamcinolone acetonide targets the posterior segment more selectively, achieving higher retinal drug levels and lower anterior segment exposure, potentially reducing the steroid-related complications. So the aim of our study was to estimate the effects and safety of the suprachoroidal triamcinolone acetonide injections in the treating patient with resistant diabetic macular edema. So the study design was the interventional quasi-experimental study. The study was conducted at Al Ibrahim Eye Hospital between the July and December 2024. This was non-prevalent convenient sampling. Sample size was 45 patients. The follow-up was done on first month, second month, and third month. Parameters was best corrected visual acuity, IOP, cataract status, and OCT findings. So inclusion criteria: adults presenting to the vitreoretinal department, diagnosed with their treatment-resistant diabetic macular edema, patient considered eligible for the suprachoroidal triamcinolone acetonide injection and had provided informed consent. Exclusion criteria was that the intraocular pressure was more than 20 mm of mercury prior to injections, macular ischemia, and presence of visually significant cataract, any renal disease or ocular hypertension, or they had posterior subtenon triamcinolone acetonide or intravitreal triamcinolone acetonide within the past 3 months. So what is the resistant diabetic macular edema? The patients who received 3 consecutive monthly intravitreal anti-VEGF injections with no significant improvement in central macular thickness on OCT or best corrected visual acuity on Snellen chart. The procedure was after all aseptic measures, 0.1 ml triamcinolone acetonide was given under topical anesthesia through the suprachoroidal route using a modified 30-gauge needle insert in the superior temporal quadrant. The needle was gradually withdrawn and the cotton tip applicator was applied to minimize the reflex at the injection site. Moxifloxacin eye drops were applied to the cornea. Follow-up was done at 4, 8, and 12 weeks. Complete eye examination and OCT imagings were repeated at third month. Study population corrected baseline mean best corrected visual acuity was 1.1 and the baseline central subfield thickness was 638. Best corrected visual acuity and central subfield thickness showed progressive and significant improvement over the 3 months following suprachoroidal triamcinolone acetonide. The best corrected visual acuity was 1.1 at the before the injection, then and 1 month it was 0.7, at second month it was 0.4, and at third month it was 0.3. And the central subfield thickness was 638 before the injection, and the average was 463 at the first month, 395 at second month, and 309 at the third month. The visual acuity curve shows a steady improvement following suprachoroidal triamcinolone acetonide injection. The largest functional gains occur between the second and third months, consistent with the pharmacokinetics of the steroid therapy. The pattern aligns with the previously published studies demonstrating early and sustained best corrected visual acuity improvement with the suprachoroidal steroid delivery. Central subfield thickness reduction is the most pronounced in the first 2 months, reflecting rapid edema resolution after the steroid administration. Continued decline into the third month demonstrated the durability of the therapeutic effect. The magnitude of central subfield thickness reduction parallel improvement reported by studies such as Jamil et al., Navar et al., and Akhlaq et al. Reinforces the reliability of the suprachoroidal triamcinolone acetonide as a macular edema reducing treatment. So the suprachoroidal triamcinolone acetonide significant and sustained improvement both best corrected visual acuity and central subfield thickness in the patient unresponsive to anti-VEGF therapy. Outcomes are concerned with multiple published studies supporting suprachoroidal steroid as an effective option for the refractory diabetic macular edema. While suprachoroidal triamcinolone acetonide is a generally safe, short-term IOP elevation remains an important consideration, especially in patients with glaucoma risk factors. Most IOP rises respond in literature are transient, returning to baseline within the months. Overall, suprachoroidal triamcinolone acetonide represents a targeted, higher bioavailability, lower anti-segment exposure and therapy, and promising functional and anatomical benefits. So, in conclusion, the study findings demonstrate that the suprachoroidal triamcinolone acetonide injection significantly improved visual acuity and reduced central subfield thickness over 3 months follow-up. The progressive enhancement in the best corrected visual acuity and consistent reduction in the central subfield thickness highlight the efficacy of suprachoroidal triamcinolone as a therapeutic intervention for the management of retinal conditions associated with the edema. Thank you.
I would also be presenting on the role of suprachoroidal versus posterior subtenon for long-standing cases of diabetic macular edema. So as you all know, diabetic macular edema is the potentially blinding cause of treatable blindness, and unless it is treated well, which normally happens in our country, the cases get prolonged, the eyesights turn into very bad, and unfortunately, due to the incident of a series of infections due to anti-VEGF about a couple of years back, the role of Avastin is still limited to very selected centers now, and that's why people are losing eyesight. So apart from anti-VEGF, the other options which are relatively cost-effective as well are steroids, and as we have seen that there is an inflammatory component in the diabetic macular edema as well, so there comes the role of steroids in it as well. We have seen the role of long-term implants with side effects of raised intraocular pressure and cataract formation along with inflammation as well. So there was always a potential to use other routes of treatment to prevent these complications due to steroids. So this was a small study to evaluate the comparison of posterior subtenon versus suprachoroidal. It was done in CMH Multan this year, and these were the cases that were selected. All patients received either an injection of suprachoroidal triamcinolone or posterior subtenon. So as you know, the suprachoroidal space provides a very safe area that is restricted to the back of the eye, and it prevents the complications to the intraocular pressure and cataract formation. And on the photograph of the right, you can see there is only 1 millimeter of needle that is inserted. This is the video of briefly of the procedure of suprachoroidal injection. You can see we give injection perpendicular to the sclera at about 4 millimeter from the limbus, and the specific suprachoroidal needle that just goes 1 millimeter inside, and then it is injected. So compared to that, the posterior subtenon injection, as you know, you have to dissect the conjunctiva and then go inside with the posterior subtenon cannula. There is always a chance of reflex in that, which is not there in suprachoroidal. So as far as the results were concerned, they were mostly comparable between the both of them. And you can see 1 month post procedure, there was almost a 37% improvement of visual acuity, and the mean central macular thickness also decreased around 50% in 43% cases. However, by 3 to 4 months, the mean improvement of vision gradually was a bit less as compared to the earlier results, and that is a bit of query for us to evaluate further whether we should give follow-up injections or to add anti-VEGF or some other options for treatment. So my concluding remark would be that although these mode of treatment provide a very safe option for treatment, there were minimal cases of cataract formation or glaucoma which requiring treatment, but they were not able to fully rectify or treat the diabetic macular edema with one single injection alone. So I would recommend or suggest that although suprachoroidal and posterior subtenon provide a safe route for effective resolution, but we would definitely require augmentation with anti-VEGF, and they would not be replacing the gold treatment of the diabetic macular edema, which is pan-retinal photocoagulation. Thank you very much. Next, Dr. Shahzad Shafkat, please.
Assalamu alaikum, everyone. I'm going to present the post-hoc faricimab data for AMD and DMO. I'm a consultant in Dudley in the UK, and I bring greetings to you from the British Pakistani Ophthalmic Society. We are a 120 strong group of ophthalmologists of Pakistani origin who are working very closely with the Medical Retina Association of Pakistan to improve training, education, and medical retina services in Pakistan. So I'm going to talk about FarWide. FarWide is a data collection service based on MediSite electronic patient record, electronic medical record system. Data has been collected from 34 NHS clinics, and it includes 26,883 eyes of more than 22,000 patients. The inclusion criteria were a documented diagnosis of neovascular AMD, no RVO or DME was present in these patients. No participation in any intravitreal injection trials. They had a conclusive anti-VEGF history, and one or more faricimab injections were given on or after June 2022. They had ophthalmic assessment, treatment, and diagnostic information, which was all obtained from the electronic medical records, and data was collected between June 22 and June 2025. Data capture was limited to what is collected in routine clinical practice, and what I'm going to say is specific, obviously, to UK and may not be applicable to other areas. So the number of patients who received one or more doses of faricimab between June 22 and 2025, there were 25,000 plus patients, 31,289 eyes. The study inclusion and exclusion criteria were applied, and the numbers were 87.4% patients, 85.9% of the eyes met the inclusion and exclusion criteria. And we have data, 24-month data on these patients, 4,667 patients, 5,582 eyes. Out of these, 23.6% were treatment-naive patients, and 76.4% were treatment-experienced patients. So if we look at the data, treatment-naive eyes, 743 patients, visual acuity at baseline and visual acuity at 24 months, there was 4-letter gain or nearly 1-line gain in vision. The percentage of eyes with 70 ETDRS letters, which equates to 612 vision, which is the minimum vision required for driving in the UK, was 30% at baseline and increased to 42.3% at month 24. So the treatment was able to improve vision in people who need to drive, and obviously everybody needs to drive. So that was found to be a very useful indicator. In previously treated or treatment-experienced eyes, the vision stayed almost the same. So 69 letters, and 24 months later, 2 years later, 68 letters. The percentage of eyes with driving level visual acuity was 49.6% at baseline in treatment-experienced group, and it was 46.3% at month 24. So it was able to maintain driving vision in the vast majority of patients that were treated. If we look at the number of injections in the treatment-naive eyes, in the first 6 months, a mean of 4.7 injections was given. And then if you look at the next 3 blocks, 6 monthly, the frequency of injections goes down. 2.3%, 2.3 injections, 2 injections, and 1.8 in the last 6 months of the 2-year period. If you look at the previously treated group, they received 4.5 injections in the first 6 months, and then over the next 6-month blocks, you can see the numbers going down. But the numbers in the previously treated eyes always were higher than the treatment-naive eyes, because these were what we call high flyers, people who need a lot of injections, and that's the reason they were switched in the first place. So far-wide is a 24-month results, highlights the effectiveness and durability and safety of faricimab in the real world. If you look at effectiveness, visual acuity improved when treatment-naive patients remained stable in previously treated patient group. A high proportion of treatment-naive patients derived driving vision at 24 months compared with baseline. Mean number of faricimab injections declined sharply after the first 6 months, and then declined further, and in the last 6 months of the 24-month period, they were having between 2 and 3 injections only. The rates of intraocular inflammation and endophthalmitis were low and consistent with the phase 3 faricimab trials, as well as the US FAR Retina trials. So Tenayan and Lucerne originator studies and the real-world study had very similar numbers of intraocular inflammation and endophthalmitis. FAR-WIDE is the largest real-world study evaluating faricimab treatment and outcomes outside of US. So we look at the FAR-WIDE DME data. Again, same data collection was done from 34 NHS clinics using the Medisoft electronic medical record system. More than 77,800 patients, 10,936 eyes, and the inclusion criteria and exclusion criteria were very similar. Documented diagnosis of diabetic macular edema. They didn't have any neovascular AMD or retinal vein occlusion. They hadn't participated in any other intravitreal injection trials. Definite history of anti-VEGF use, and one or more faricimab injection on or after June 2022. Ophthalmic assessments were carried out like we do normally in our clinics, and data was collected between June 22 and June 2025. So data capture was limited to what we normally do in the clinics: vision, central foveal thickness, recording any intraocular inflammation, and endophthalmitis rates, and injection frequency. So between June 22 and June 2025, patients who received one or more injections of faricimab, 9,964 patients, 14,245 eyes. People who met the inclusion and exclusion criteria, 78.8% of patients, 76.8% eyes met the inclusion and exclusion criteria, and the people who completed their 24-month follow-up period in the real world, they were 967 patients, 1,311 eyes. Out of these, the large majority were treatment naive, 26.8%, whereas 73.2% were previously treated eyes. If we look at the treatment naive group, baseline visual acuity, ETDRS, went from 65 letters to 70 letters at the end of 2-year period, so 5-letter or 1-line gain in visual acuity. The percentage of eyes with 70 ETDRS letters or 6/12 vision was 48.4% at baseline and nearly 55% at month 24. In the treatment experienced group, visual acuity stays the same. Baseline 70 letters, mean baseline was 70 at month 24. So the percentage of eyes with driving level vision was 53.2% at baseline and nearly 55% at month 24 at the end of the 2-year period. So the more people treated were able to maintain driving vision. We look at the number of injections in the first 6 months, 4.5 in the treatment naive group, and then you can see on the next 3 slabs how the number of injections goes down. So month 7 to 12, 2 injections, 13 to 18, 1.5, and then 1.4. And this is the benefit of faricimab, the durability effect that you get over other anti-VEGF injections. And we can extend up to 16 weeks in AMD and DMO once they've had a loading dose of 4. So everybody gets a loading dose of 4 injections, then a mandatory injection 2 months after the 4th. And after that, we can extend straight away to 16 weeks if the patient is deemed applicable. So if you look at the previously treated eyes, 960 patients, number of injections was 4.4 in the first 6 months, and then you can see it going down to 2.3 injections, 2 injections, and 1.7 injections, so nearly 2 injections in the last 6 months of the 24-month follow-up period. If we look at the pooled adverse events across both, in fact, all 3 conditions, neovascular AMD, DME, and RVO, in treatment-naive patients, the percentage of intraocular inflammation events per injection was 0.15%, and the percentage of endophthalmitis events per injection was 0.03%. So that there were like 31 events in 115,000 plus injections. And in the previously treated group, exactly the same. 0.15% intraocular inflammation, and 0.03% percentage of endophthalmitis incidence. So far-wide DME is a 24-month results of post-hoc results for faricimab in the UK. Effectiveness, visual acuity improved in treatment-naive eyes and remained stable in previously treated eyes. A high proportion of treatment-naive and previously treated eyes were able to maintain driving vision at 24 months compared to baseline. It's a durable injection, and you can see after the first 6 months, a significant decrease in the need for injections over the next 6 months block. And the rates of intraocular inflammation and endophthalmitis were low and consistent with the phase 3 Tenaya and Lucerne, as well as the Yosemite and Rhine diabetic patient group, and very similar to US for Retina study, which I'm going to present later. So FAR-WIDE is the largest real-world study evaluating faricimab outside of US, and it shows effectiveness and safety of faricimab. Thank you very much.
Thank you very much, Dr. Shehzad.
100 supply, 100 demand, harmony. 90 supply, 100 demand, then the problem arises. So load shedding. So best option is load shedding. You cannot change the vessel structures. It is microangiopathy, and you cannot reverse it. So I 100% agree with Professor Hamid Mahmood Bhatt that once there is a demand, the areas where you can eliminate the one who are asking for food so that you can save the central area. And the second question for all is, you said that when there is a macular thickening, what is the cutoff point where we can say that you should not apply laser to increase that thickness at the macula? So cutoff point. And the second is there any role of micropulse even in those cases?
I think I've been educated by my dear class fellow Shehzad last time we came to SIMS. And there in UK, as I understand, the cutoff is 400 microns. Below 400 microns, if it is above 400 microns, you qualify for anti-VEGF injection and intervention. But in our setup, because there it is something which is regulated, but in our setup, if I say you can bring down to 300, 350 if you feel like, and also tailor it with the visual acuity of the patient. If I have to lase somebody with macular edema, and if I see some areas of leakage, some areas of focal, by definition, interestingly, I asked this question to one of the sessions. CSME, according to ETDRS study, CSME, by definition, has 6/6 vision. It was a surprising thing for, I asked this question to the audience, and everybody feels like अगर macular edema है तो vision तो कम होना ही चाहिए. लेकिन जो original ETDRS की classification है, उसमें patients का 6/6 vision भी inclusive था. That is a very important thing to remember. लेकिन जब से OCT आया, तो central involving and non-central involving पे आ गए हैं, which has simplified the discussion. दोनों को अलग कर दिया. और दूसरी चीज़ ये है कि एक बहुत बड़ा चेंज एंटी वेजेफ से हमें, वी बिलोंग टू द प्रीवियस जनरेशन, लेकिन वी आर वेरी लकी वी आर ऑल्सो लिविंग इन दी AI जनरेशन. सो आई फील वेरी प्रिविलेज एंड फ्रॉम दैट पर्सपेक्टिव. तो द पॉइंट इज कि जब भी हम लेज करते थे, फोकल करते थे या PRP करते थे, हम पेशेंट से कहते थे 2-3 लाइनें ड्रॉप होंगी आपकी, तो आप इससे डरे नहीं, ये ऐसे होगा. तो वो कहते थे जी यार. और फिर जो लेट आते थे उनके बारे में कम्युनिकेशन स्किल्स रियल लाइफ जो हमारे लोकल होती है वो ये होती है कि जी वो थोड़ी बहुत जी नज़र है सी थोड़ी जी वो भी लेज़र ला के साड़ देती है. बट दे वर सो लेट इन कमिंग. तो ए गुड ट्रीटमेंट ऑल्सो इज सॉर्ट क्या कहना चाहिए, इज सॉर्ट ऑफ रिजेक्टेड इनडायरेक्टली और नॉट एक्सेप्टेड इन द पेशेंट पॉपुलेशन. तो आपने बताना होता है कि आप इतने है और क्वालिफाई करना होता है. सो कम्युनिकेशन स्किल्स इज द मोस्ट वाइटल स्किल. चाहे वो अनपढ़ बंदा है, उसको भी आपकी बात 100% समझ आएगी, तो आपको उसकी ज़बान में बात करनी है. That is the thing. So coming back to Akil Kazi's question, because we have a privilege of being class fellows in FSC also. तो coming back to that, अगर if I see a central involving diabetic macular edema और उसके साथ कोई एक focal tuft भी पड़ा हुआ है, तो पहले मैं एंटी वेजेफ से उसको ड्राई करने के लिए मिनिमम जितना मैं ड्राई कर सकता हूँ उतना ड्राई करूँगा, और फिर जो पेरीफोवियल जोन एवेस्कुलर जोन से बाहर है थोड़ा सा, वो वेस्कुलर नेट से थोड़ा सा बाहर है, तो मैं उसको लाइट जेंटल बर्न लगा के स्टेबलाइज जरूर करूँगा. सो यू एक्चुअली कंबाइन एंटी वेजेफ विद PRP according to your discretion and tailor to the patient. And also you combine anti-VEGF with perifoveal focal photocoagulation also. So all these strategies are at your disposal as a retina specialist. Thank you.
Thank you for the question, Akhil. I think I'll address these things one by one. There still is definitely a role for pan-retinal photocoagulation. If people come to us, type 1 diabetics, they come to us with neovascularization, we do treat them. Even if they don't have frank new vessels, but they have large areas, more than 13 disc areas of capillary non-perfusion, and we suspect that this person is not going to come back. Amit alluded to that earlier. Young people, they type 1 diabetics, they're in the working age group, they can't come very frequently to the hospital. They have other hospital visits as well. They go to the kidney clinic, they're sometimes having dialysis, they go to endocrinology clinics. So, they've got to work as well. And the DNA rate, did not attain rate, is quite high. So if they come with new vessels on the disc, which are what we call high risk PDR, then obviously we will go straight for pan-retinal photocoagulation. If they come with low risk NVE, or even if they don't have frank NVE, we will still do PRP if they have large areas of capillary non-perfusion. Second question was, what you mentioned, that the central foveal thickness increases after pan-retinal photocoagulation. It used to, because we used to be using, very harsh laser and large burns. Now we're using pattern laser, Pascal laser, which is, much lighter. Secondly, before treatment, in the majority of cases, we do an FFA. We look for the area of the junctional zone between perfused and non-perfused area. That's the area which is rich in VEGF. That's the area which is releasing all the chemokines which are going to cause neovascularization. That area called the penumbra, we target that area. So it's more selective PRP rather than ablating the whole retina. If you do give aggressive treatment and you ablate unnecessarily, if it's a dead horse, there's no point kicking that area because it's not releasing VEGF. No point in giving PRP to that area. Just treat the penumbra, the junctional zone between the vascularized and non-vascularized area. So that will limit the number of PRP applications as well. Because in the old days, when we were here and we used to give argon blue laser, almost everybody ended up with epiretinal membrane. Now even nowadays, there is a little bit of epiretinal membrane once they've had aggressive treatment, 3 or 4 treatments, because not everybody conforms to medical treatment. The mainstay for diabetic retinopathy is still the medical management, the hypertension, the HbA1c, the cholesterol levels, the sleep apneas, and all those other things that we talk about. And then whatever is left behind, then we treat. Now, the other thing is we talked about central foveal thickness of 400. That's only for central involving DMO. And it's only in the UK because it's based on the drcr.net trials that showed that people who had better than 618 vision or less than 400 microns, whether you treat them with Lucentis or Eylea, it didn't make any difference. But people who had central foveal thickness of 400 plus, they did really well with anti-VEGFs, and the vision gained with that specifically. So that's why 400, that's where it comes from, the drcr.net trial. So I think I've answered your question. Yes. So I personally don't have any availability of micropulse. So we use Pascal 577 yellow, which is the latest pattern laser. It is also very gentle laser. With micropulse, you get interrupted, profile. So it's an on-off system. With Pascal, we use the endpoint management system where you can go down to about 30% cycle to reduce the intensity. And the reason we're using gentle laser is because you know that in pigmented races particularly, you get laser creep. The spot size is going to be twice the size in 2 to 3 years time. But with Pascal and with micropulse, you don't get that. I personally don't have any experience, but there are quite a few case reports of micropulse being useful.
You mentioned DRCR the cutoff is 2025, not 618. Is it 618 for?
So we use 618 and 400 microns as the cutoff.
Which is not according to the guidelines of DRCR Protocol V, because in USA we observe patients. We can observe patients who have macular edema and vision better than 2025 based on Protocol V.
Right. Okay. So 2025 would be like 6/9 vision, right?
Yes.
Before, one thing which for the benefit, I always look forward to the residents. The target tissue for the PRP is the retinal pigment epithelium. You have to have a gentle burn. The gentle burn means you are actually debriding the outer layers of the retina, which is the rods and at not the cones, but selected because you're working in the periphery. दूसरी चीज हमेशा याद रखें, the oxygen consumption of the retina per gram tissue or per centimeter cc is more than brain, and it is not directly supplied with blood. This is basic physiology. The highest oxygen consuming tissue in the body has no direct blood supply. Therefore, you want to reduce the oxygen burden. कई दफ़ा हम पार्ट 2 के एग्जाम में भी पूछते थे कि जी आप PRP के लिए टारगेट टिश्यू क्या है, or what is the mechanism of PRP actually working and reducing the oxygen demand? How does it do it? And then secondly, with all these fancy lasers, micropulse and all that, if you do a gentle burn, it's just barely visible. Even with conventional laser, you are getting equivalent results. So this is also basic laser technology to me. Over to Hina.
I just need 20/25 or better vision. They said that the likelihood that this patient would maintain vision over a period of 24 months without treatment is very high. So their guideline was don't treat.
Hina, could you?
Sorry. I just wanted to just add to that comment here that with DRCR.net Protocol V, which was a research study, they only came up with the stats that the likelihood that a diabetic patient who's maintaining 20/25 vision or better vision is very high, that he'll maintain that vision over a period of 2 years without treatment. So their recommendation was don't treat. But when that translated to nice guidelines for treatment, which is obviously an NHS-based, जिसमें उन्होंने वो सारी financial वो भी करनी होती हैं. So उसमें वो visual acuity as well as the threshold for treatment define कर रहे थे, जब तो उन्होंने उसको बढ़ा दिया. But I get your point, because there are people who have very high CMTs and yet they're maintaining good vision, and there are people who are barely making it beyond 300 microns and their vision is 612. ये मेरा आता है. And then you just treat according to the whole.
I think in that ischemia has to be playing.
Exactly.
So we look at central foveal thickness 400 micron. We actually, even if they have 6/9 vision or 6/6 vision, which is unlikely with central foveal thickness of 400, we still treat. So basically, it's because NICE looks at not just effectiveness; it looks at cost effectiveness as well.
We don't have any experience as far as the micropulse laser is concerned, which is a new thing to hear. And I think the micropulse laser is more towards the CSR rather than diabetic retinopathy. So we haven't used it micropulse as far as the diabetes management is concerned, but do have their role in CSR. Yes.
We have this micropulse laser. So
आइडेंटिफाई करेंगे
I am Dr. Riaz, and I am working at POB Eye Hospital, Karachi, and I am doing medical retina. And so I have many patients. We did the many injections Avastin. Mostly we are giving the Avastin. So after many Avastin, patient is not improving, and diabetic macular edema is not improving. So at that time, so means they cannot afford the higher level of price of the injections. So we don't have any other choice. Sometime even after the suprachoroidal injections, the macular edema is not improving. So we are going to treat with them. So I got the results are good, and macular edema is decreasing. So after decreasing the macular edema, so then we again start the Avastin. So we have patients like this.
Do you treat over the foveal area?
Yes, 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 yes.
How do you then see the results? Because obviously there's a burn.
Actually, in the machine they have the setting like this. So this is a very minimal. We cannot see the burn.
Do you have blue peak autofluorescence?
No, we have the other yellow.
No. I mean, if you have autofluorescence, then it may show.
Yeah. After sometimes we are doing this autofluorescence.
What are the settings that you make on the microprocessor? Because that is very important.
So it is automated in the machine. So yes, it is automated actually. We have this one in the system. So there is a 0.05.
Is it Norness?
Yes, Norness.
Hospital like LRBT there, and you're doing a wonderful job in Karachi, I know that. But I think you must produce with evidence and a paper the next time.
Inshallah.
That will be helpful to all of us.
Inshallah.
We will certainly, MRAP will support you on that, but everything should be documented because this is a new thing and we need to move forward on this thing.
Okay.
And it will help.
Yes, inshallah, sure.
अब तो मेरा भी बाल मेरे भी अब काफ़ी कम हो गए, काजी साहब के भी काफ़ी कम हो गए. तो काजी साहब का जो स्टाइल होता ना, बड़े डरते थे हम इनसे. काजी साहब का जो बॉलिंग स्टाइल होता था ना, वो एक बड़ा क्रिकेटर होता था, बड़ा फास्ट बॉलर जो लिली के साथ कंबाइन करता था, थॉमसन. और थॉमसन जो था ना, वो यहाँ से बॉल करता था, मतलब पता ही नहीं लगता था कि इधर तक बॉल आएगी कहाँ से. तो काजी साहब बिल्कुल थॉमसन के बाल इनके जो थे ना माथे के ऊपर, आंखें भी नजर आती थी इनकी जब सामने से बॉलिंग करा रहे, क्योंकि अगर बॉलर के साथ आई कांटेक्ट भी नहीं है और उसका हाथ भी नहीं नजर आ रहा कि कहाँ से आ रही है, तो ये सवाल भी उन्होंने उसी तरह ही किया है. तो ओवर टू यू सर.
Sir, thank you very much.
Now coming down with the modern treatment, but microangiopathy is the next frontier. And there is a work going on, I am aware, with the companies that if they can control the progression of angiopathy, so we will have a big breakthrough medically in the coming few years. So what I would say is this treatment, what you are doing is fine, but also add endocrinology advice to your patients if you are coming to you for retinopathy management, because that is now the next important thing. Blood pressure, as you mentioned, HbA1c management, absolutely, and fenofibrate is now being added up as a treatment for diabetic retinopathy. So I think those are very important things as well, rather than just going for wholesale nuclear option of PRP to everybody. Thanks.
I would request this session to be closed, and there was a group photo session for the speakers. If they can come forward, please. Thank you.